Well, I'd like to call this meeting to order. It's 9:08 a.m. on the computer I'm using here today. And we will now begin the portion of the business meeting to take public comment. The purpose is to allow members of the public to directly address the Washington Medical Commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. Note that we will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comments at Washington Medical Commission committee meetings. The public can also contact staff during normal business hours. We also welcome written comments as well. Ms. Boyd, how many people have signed up to speak?
So I'm sure we have some hands raised in the chat. And then I do have two written comments we received to read into the record. So why don't we start with the verbal comments since we have so many, and then I will move on to the written comments. So Susan Olson, you are first.
Good morning. My name is Susan Olson. I'm a lifelong resident of Washington State. I'm also a chronic pain patient under the care of multiple physicians for lupus, ankylosing spondylitis, and fibromyalgia, with chronic pain being listed also. In the past 6 years, I've had 16 surgery encounters, ranging from cervical fusion with a lower back, 9-level fusion, 11-level decompression. I currently have over 106 pieces of hardware in my body. My most recent procedure was a double mastectomy on July 10th. I'm 9 days post-op today. I fully support the petition submitted by Maria Higginbotham. I currently have an amazing medical team that has listened and documented what I go through so they can provide the pain control that best works for my individual situation. Each chronic pain patient should have that same experience. As I approached my double mastectomy, the intense fear of lack of pain control consumed me. When I had my lower back surgery in 21 at Harborview at a teaching hospital, I had to fight for pain control, and the memory of that fight was overwhelming as I faced this surgery. The reason I stress teaching hospitals is because this is where we are training our future providers. And this is where clear direction is so important. Ms. Higginbotham's changes give that clarity and direction. While going through the mastectomy, I've had the great team at the University of Washington, Fred Hutch, and Seattle Cancer Care Alliance that worked with my pain clinic and developed a plan that allowed me to continue my recovery comfortably, not pain-free, but comfortable. And without them, I wouldn't be here in front of you today. No one should have to feel the stress and worry about pain control when facing each day or a surgery encounter. If a patient is in compliance with the physician pain contract, there should be no requirement to comply with a predetermined MME/MED number that simply may not be appropriate for that specific patient. Clarifying the language in that will help the prescribing physicians have a clear understanding of the WACs, which in turn will result in better patient care. Thank you for hearing me today.
Thank you. And then Cindy.
Good morning. I'm Cindy Hohenhaus, and I'm co-chair of Washington Patients in Intractable Pain, or WashPIP. Thank you for the opportunity to comment today. Washington Patients in Intractable Pain advocates for access to appropriate pain care for those living with intractable pain. We operate in the gap of well-intentioned policy and real-to-life patient experience. We draw attention to potentially harmful patient impacts, which would cause further barriers to care. We also ask for representation anywhere opioid policy or actions are discussed or acted upon. WashPIP continues to hear the outpourings of stories from disenfranchised patients. 7 years since HB 1427, Washington continues to measure the success of opioid prescribing by reductions in the number of prescriptions, lowering MED, and minimizing transitions from subacute to chronic care. Pain care is no longer individualized in Washington. The treatment of pain is to a number. Washington Medical Commission is a firm ally in producing reasonable prescribing rules that allowed for individualized care. However, other contributing factors have overridden that care and replaced it with a myriad of restrictions. What are those restrictions? What are the patient outcomes? How do we best support our providers treating chronic pain? How do we repair it and prevent future patient harm? It is of the utmost importance that relevant data is compiled to examine the causation of the deterioration of pain care in Washington, the human outcomes, and potential solutions for these patients. It is time to put the magnifying glass on this issue in the form of a work group or other suggested form of investigation. I ask for your help to move forward in examining the patient tragedy of numerical-based pain care and to help us move back to a place of individualized care based on patient outcomes. Thank you.
Thank you, Cindy. Thank you, Cindy. And then next we have Catherine Burton.
Yes, hello. I apologize for my camera not being on. I am still in bed. So I am a 39-year-old chronic pain patient with Ehlers-Danlos syndrome and dysautonomia, as well as bilateral thoracic outlet syndrome. My last pain-free day was 11 years ago. It's getting harder and harder to get adequate pain medication month to month, even when I am personally lucky to have a great doctor and pharmacy. And even with that, sometimes it's very stressful. I don't know month to month what's going to be covered, what's going to have adequate supply, etc. So, as previously been stated, I support the petitions by Maria Higginbotham to make clear that there is no max MME dose in Washington State, that unnecessary forced tapers should be considered below the standard of care, and adding further exemptions for rare diseases and chronic pain would be incredibly beneficial to our community. I personally wanted to add that in the WAC code for tapering considerations, number 2 is the patient experiences a deterioration in function or pain. A lot of conditions that chronic pain patients have, including myself, are degenerative, genetic, and chronic. And personally, I have a fair to poor prognosis. So a lot of patients in this population will experience a deterioration in function and pain on their current dose at some point in the future. I don't think that solely should be considered a consideration for tapering. It might just be the disease progression that certain patients are having that require not a taper, but in fact an escalation in dose to find a new normal for that patient and their condition. My second point in the WAC code is under other treatment modalities are indicated. I would just note that a lot of other treatment modalities, as much as we would love to do them, are not covered by insurance and so are not affordable. So I don't know if something could be added, just acknowledging that not all patients can do other treatment modalities as indicated by their physicians. Thank you for listening to me and for having this comment read into the meeting today.
Thank you. And then next is Jennifer Davies.
Good morning. Thank you for having me today. My name is Jennifer Davies, and I am currently almost 54 years old. I've been a chronic pain patient since October 27th, 2003, when I had a incredible flare with transverse myelitis bilateral, which was my presentation of systemic lupus. It took a long time to get the diagnosis. At the time that I got ill, it took 4 to 7 years for a person with systemic lupus to get a diagnosis. Now with modern technology, it takes 5 to 7 years. And part of the problem with that is doctors are not super knowledgeable about systemic lupus, and it is a criteria-based diagnosis, which means that you're looking at relational data and you cannot look at just one test. So what that means for women in particular, since it impacts mostly women, is that they suffer agonizing pain for many years before they get the diagnosis. And usually what happens is somebody is getting a raging flare that causes possibly life-threatening or life-altering experiences. In my case with transverse myelitis, I lost mostly my ability to walk, which I did gain that back. I did everything. I did all the biologics, starting with hydroxychloroquine, methotrexate, and then I moved into Cellcept and cyclophosphamide. I'm no longer willing to do cyclophosphamide because it is full-blown chemotherapy, which gives you a 30% chance of getting bladder cancer within 10 years. Since 2017, when my rheumatologist, a very prominent, wonderful human being, who was also my pain specialist, decided, well, he's going to retire in a couple years and did not want to treat pain anymore because most doctors fear disciplinary action in this particular culture. I went on to have to find another pain physician, and I was particularly lucky. Um, I I always wonder when it's going to be my turn because so many people that deserve pain medication are not getting it, but yet here I am getting it. So I feel like it is part of my responsibility to advocate for others and not just myself. I did take a move to Portugal, but came back where I was treated. There's no DEA regulations, but doctors will treat you. I had a rheumatologist there that was also my pain doctor, but my son got sick with lupus. So mama had to come back, and this is where I stay. He does not have pain disorders, but I certainly worry about him. My mother suffered from Crohn's, where I had to be very active in pain management and had to go toe to toe with her physician, who basically would not treat her, and I did eventually get that treatment. My concern is the misinformation and disinformation regarding opioid therapies, even that you see in the research. There is a lot of documentation, I will end this shortly here, that suggests that opioids are not efficacious when treating autoimmune disorders, and medical students are being taught that. And that is just not the case. And when you surface down and you drill down into the research and see who's conducting it, and you see that people with intractable pain, which is severe pain. It's not like breaking an ankle or having or a psychosomatic disorder. It is severe pain that most people will never experience in their life, way beyond childbirth for me and others. I digress just a little bit because I'm trying to get a lot out. But I would like to see, I definitely support Maria Higginbotham's petitions. And I really respect her for being an ill person and fighting for not just herself, but others. It's a very, very difficult thing to do. I kind of bailed out with Portugal, and I'll probably bail out again and go back eventually because I just don't like seeing what's going on with medicine. It not only affects opioid medications, but it affects any type of off-labeling prescribing and other medications as well. More and more patients will start to suffer in the future, including patients that go in for surgeries. As a result of steroids, I've had to have 2 hip replacements. So that hasn't been a good time. Thank you very much.
I apologize.
No worries.
Ms. Higginbotham? Oh, she's
muted, I think. It looks like the mute sign's on.
It looks like she dropped off too. She's probably having technical issues.
Am I now?
Yeah, now we can
hear you.
Okay, I had to push 4 buttons to make that happen. Basically, I'm not going to take up much of your time because I have already expressed most of what I wanted to say in my petitions. I want you to know, though, that I am very appreciative of all the work that the Commission has been doing. I know that you know that what is happening to patients, especially chronic pain patients, is a dire situation, and many of them are afraid to voice their concerns or the things that are happening to them because they fear if they talk that they are going to lose their care. So it's a catch-22, and it's a difficult situation. Doctors are afraid as well, and that is another situation. And I agree with Cindy, we need to dig down and find out what's going on. Because I have talked to so many of them and they just seem to not really know what rules and what guidelines they're supposed to be following. And so they just, a lot of them have chosen to just quit practicing, and that leaves thousands of patients without care. And other doctors don't want to take chronic pain patients. They have signs on their doors, "We do not treat chronic pain." And that leaves a lot of people without an option, and it shouldn't be that way. So I am grateful to you, and I hope that things can get better with working together. Thank you.
Thank you, Maria. Kat has.
Sorry about that. I was muted. I wanted to help and come in support of Maria. We worked hard on drafting those petitions to try to make more inclusionary language, and it impacts a number of us. 70% of chronic pain patients are women, but clinical trials were not even done on women until the 1990s. Ehlers-Danlos syndrome, which I know that Maria has, other people have talked about having, I have, has been called the most neglected medical condition in history. It's a multi-symptom disease. It can cause your organs to rupture or break down. It causes joint pain throughout our lives. It's an intractable condition. It causes conditions like adhesive arachnoiditis, which has nothing to do with spiders. It's called the devil's disease because it's about the lining of your spine and adhesions forming to the point where it feels like bugs are running down our legs. I also suffer from complex regional pain syndrome. And to give you an idea what that's like, the McGill Pain Index has a scale of 1 to 50. It's above childbirth, it's above most forms of cancer, and it's nicknamed the suicide disease. The type that I have is ranked a 47 out of 50. I'd like to talk a little bit about what I do in my role with the American Pain and Disability Foundation because I think it's relevant here. I'm our Director of Communication, Law, and Public Policy, which means that I have initiated legislation and gotten sponsors in certain states, have worked on federal legislation for the past 6 months, and of course have been active in agency rulemaking and public policy. Why does this matter? Because my experience is not a one-off. This is the experience that I hear from every intractable pain patient or every patient who has severe chronic pain. We all have stories about how we were properly treated at one point and that's no longer happening. I was really excited to see that Dr. Turman mentioned exempting sickle cell disease and that not all patients should be tapered, but that language is incredibly vague. What does that mean? In 2019, Alexander Redfield, who was the director of the CDC at the time, said that there should never be an involuntary taper, meaning no dose cuts or discontinuation of medication. The data has borne that out. The Journal of the American Medical Association and many other reputable peer-reviewed publications have indicated that involuntary tapers lead to a 75 increase in emergency department for visits, a 75 increase in mental health crises, and a 25 increase in suicide. So I'm very excited and appreciative to you all for the steps you are taking. I would encourage you, however, to listen to the stakeholders and take them farther. Thank you so much for letting me attend.
Thank you. And then I will read the two that we have. Hold on just a second. Okay, so we have two written comments. So the first one is from Douglas Stamp, who is a PA. He's practicing pain medicine at Peninsula Pain Clinic in Silverdale, Washington, and he wants his comments to be read for today's meeting. He supports the adding of rare diseases to sickle cell disease exemption. There are many diseases that warrant exemption, as does sickle cell, that require chronic opioid pain management. Adding rare diseases incorporates many of them. He also agrees that the additional clarification is needed from the WMC board as to who qualifies, as not all chronic pain patients need to be tapered, including language already outlined by the CDC in support of stable legacy patients to the WMC opioid guidelines, will be helpful for those particular patients and their prescribers. And then we have one more. Let me find it. And then this is from Brenda Williams. Their public comment is that for WAC 246918870, which is the PA WAC, but we have an identical one for the MDs, I support the recent changes, i.e. adding the exemption for sickle cell patients, noting that biological testing should not be used in a punitive manner and that not all chronic pain patients should have their prescriptions tapered. However, we need to go further in minimizing restrictions and complications for chronic pain patients to continue their medications. The below petitions address the specific requests our community has. Also, Maria Higginbotham from the Washington Pain Advocacy Group has submitted official petitions to address these issues, and I support all of the following. 1, make it very clear in the rules that Washington State does not have a maximum MME. Address forced tapering. Due to a change recently made by the AMDG on their MME calculator, practices all over the state have initiated forced tapers. I'm asking them to add, if a patient is compliant with their treatment plan, then any forced taper or reduction medication is a violation of state law and below the standard of care. Since the WMC is adding an exemption for sickle cell patients, one of 10,000 rare diseases, I am asking that they add an exemption for all rare diseases which affect over 30 million Americans. Also add exemption for chronic pain patients. Oh, someone find that person. Okay, thank you. I have also attached the comment previously submitted via the website, which I did not find the attachment, but yeah. So that is the two that we have that were in writing. And then it looks like we might have one more hand raised. Let me stop sharing. Hold on just a second. My computer is locking up a little bit. Okay, it looks like Martha Marty Mione, you'd like to speak?
Yes, I certainly would. I would like to support Maria Higginbotham's statement and appreciate the fact that Doug Stamp, my provider, has given a statement. I am being forcibly tapered right now. I ruptured L5S1 on February 14th, 2000 at work. I've been the model patient from day one, and this is just going to devastate my life. What's happening? I'm a caretaker for my husband, so not only does it affect me, it affects him. He's had a kidney transplant. He's legally blind. I'm sorry if I'm getting a little emotional. Just help, please. Thank you.
Thank you. That is all of the public comments that we have. And then Dr. Domino, just real quick, we do have a new commissioner in this meeting today, Dr. Daniel Cabrera.
Okay. Dr. Cabrera, do you want to introduce yourself?
Yeah, happy to. Thanks for having me, and I'm happy to be joining. My name is Dan Cabrera. I'm an internal medicine physician. I work primarily as a hospitalist at Harborview Medical Center under the UW Medicine umbrella. And I've been there now over a decade, 12 years. I don't know if there's anything else you wanted to hear.
No, that sounds great. Thanks a lot. Nice meeting you virtually.
Yes,
And
likewise.
we will have some in-person meetings coming up, so good to see you in person as well.
Yes.
Right. So I just want to say, because I didn't get a chance to read the last statement, this concludes, which I already did, the public comment portion of the meeting. I just want to thank all those who testified and spoke at the meeting for their comments. And again, you may provide written comments at any time. We do read these as commissioners, and we value your input. All right. The next portion is my chair report. Well, I have a short chair report. I went to the WSMB, the Federation of State Medical Board meeting in June, and it was related to alternative licensing models for physicians who are trained internationally. As a long-term University of Washington and former Harborview practiced at Harborview for 25 years, but I work up at the UW Montlake. A lot of the people in our department are internationally trained physicians. They're outstanding. Yes, they do have an ability to get a license as a research and educational license. But given the mass number of retirements of physicians, older physicians in particular, especially after the COVID, and especially even worse after the post-COVID time, where there's tremendous production pressure and burnout. What has happened is there's nationally, people are looking at internationally trained physicians to help bridge some of the gaps. Particularly, the gaps are largely ones in more rural areas, and especially in areas like family practice. But even in my specialty in anesthesiology, we have gaps as well. So I thought it was an interesting thing. You'll be hearing more from Mr. Micah Matthews. I think we may be mentioning a little bit about it. He and I both attended things. My assessment is Washington State is moving along fairly well with regard to this. Pretty much, I thought, more at the forefront of things. One of the notable absences at the meeting in DC in June was one of the American Board of Medical Specialists. Okay, and one of the big problems we have is for internationally trained physicians to become board certified in the U.S., which may impact their ability to be able to bill for their services, especially when they're outside of something like the university, where we allow billing as long as it's deemed equivalent residency and fellowship certification. So anyway, that was that interesting meeting and a national problem. And I like to thank Mr. Matthews for doing such great work in this area, as well as the international physician group. That's the end of my board report. All right, the next thing we have is the consent agenda. There are two items there. They include 4.1, approval of July 19th, 2024 business meeting agenda, which is today's agenda, and 4.2, minutes of our April 26th, 2024 business meeting. Can I have a motion for approval? Sorry, I can't see everyone on the screen.
Motion to approve.
Okay, does second?
Second.
Any discussion of this? All right, all in favor? Do we approve the consent agenda? Please raise your hand or say aye.
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 Anyone opposed? Okay, the consent agenda passes. All right, the next item is commissioner training, and Ms. Heather Carter from the Attorney General's office will be talking about the Open Public Meetings Act, or OPMA. So I guess we have a training of this.
Yeah, so I'm Heather Carter for the new people. I'm the Assistant Attorney General that's assigned as your legal advisor. And I've been with the commission a little over 10 years, I think. And we are required to, you're required when you first onboard to have training in the Open Public Meetings Act, but also there's a required periodic refresher. So that's today. I'm going to probably take 10 minutes or so just to go through and refresh your memory about open public meetings. So I'm going to attempt to share my screen. Is that up there?
Yes.
Okay, great. Let me start the, okay, are you seeing, okay, perfect. Oh,
We see the slides, but you haven't gotten in slideshow mode as far as I can
okay.
tell.
I'm seeing the wrong one.
This is the problem
If
with
you go up at
multiple
the top,
screens.
yeah.
Well, I will just go through in this mode.
Now you can click on it. Yeah.
Which one is that?
Heather, were you sharing your screen or a specific program?
I was trying to share my screen.
Okay. If you share a specific program, it'll allow you to do the presentation mode. But if not, you can just
okay.
go through.
Okay, let me try that again. I'm sorry, everyone. Let's try that.
Bingo.
Oh, okay. Awesome. So Open Public Meetings Act was passed in 1971. Is it moving along for you?
We see your slide. You can push advance and we'll see if it advances.
It's not.
Yeah.
Doesn't want to go. Well, there we go. So Open Public Meetings Act was passed in the 70s. It's one of the sunshine laws or open government laws, and it requires that meetings be open to the public for certain state agencies and local government agencies. It applies to the governing bodies. So if it's a multi-member body of any government agency, those need to be open to the public, their meetings. In your case, the commission is a multi-member state agency, different from, say, an agency like the Department of Health, which has a single head, the secretary. They do not have to comply with OPMA, but as a multi-member body, you do have to comply. It doesn't apply to the courts, the legislature, agencies that have, like I said, a single individual. It also doesn't apply to certain activities that your group does or any governing body does. So your licensing meetings for professions, disciplinary proceedings, that's why your disciplinary calls are not open to the public. Other quasi-judicial matters, matters for the APA, and union collective bargaining matters do not have to be open. So what is a meeting? A meeting is anything where anytime an action is taken, and action is defined very, very broadly in this context to be any public testimony, any discussion, deliberation. Doesn't have to be a vote. So that's why even if you have a meeting where you're just discussing an issue, that needs to be open. So doesn't have to just be a time when you're taking a vote. A meeting can occur like we have today on a virtual meeting. It can occur for a in-person meeting, but it can also be a telephone call. It can also be an email exchange. So that's why I'm kind of a stickler for don't reply all, and staff kind of remedy this with blind copying you. But it's something you should know that a meeting can occur in all sorts of settings. So we need to be careful that anytime there's a quorum of the commission, which I believe is 11 of you, meet talking together or having a discussion, whether it be email or in person or online, that those meetings need to be open to the public. So final action is defined in the Act. And I just put this slide in here just to let you know or remind you that secret ballots aren't allowed. So all voting will be done in a public manner, not sort of an anonymous vote. So there are 3 types of meetings under this act: regular, special, and emergency. And really the difference is the length of notice and the requirements for your agenda that change based on what kind of meeting. So your regular meeting is the meeting you have today. It's those, I think today we're going to approve the meeting dates for 2025. Amelia takes care of this, but those meetings are filed yearly with the code revisor and are published for everyone to see. It's going to have the date, the time, usually the location. Sometimes we just put on there hybrid or to be determined, but those days and times are scheduled a year in advance. For regular meetings that are scheduled a year in advance or yearly, your agenda is posted at least 24 hours in advance of the meeting, and those are usually posted online on your website. The nice thing about a regular meeting, because it's regularly scheduled, is you can amend the agenda even at the meeting. So it adds some flexibility to use the regular meeting. So a special meeting is one that's not on that yearly calendar, and from time to time you do call these. They only require 24 hours notice that the meeting is going to occur, as well as publication of the agenda. From time to time, we have some urgent business that you need to take care of. I know during COVID, we called quite a few special meetings because there were issues we needed to have you decide on before a regularly scheduled meeting. The thing about special meetings is you cannot amend the agenda. So once you publish that agenda for a special meeting 24 hours in advance, you need to stick to that agenda. You can't add extra items. And then finally, there's emergency special meetings, and these take place when there's, like the pictures show, some natural disaster or some other, the pandemic. Those sorts of things can happen, and you can call a meeting together where notice is very limited or not at all, or as much as you can, but under that 24 hours is allowed if it's justified by an emergency. So from time to time, you do enter into an executive session, and this is where public is excluded, and you can decide what staff you want present. Staff can attend, and in some cases, staff is necessary. It's part of a regular meeting or a special meeting, and there are only certain topics that can be discussed or to justify exclusion of the public. The most common for your group is to discuss agency enforcement actions, litigation, or potential litigation. From time to time, we do take you into executive session to discuss a legal matter, strategy, what's going on in certain litigation. In those cases, legal counsel must be present in those to justify the litigation executive session. There are other delineated reasons you can go into executive session. I've got some of those: real estate sale or lease, contracts. This other one that I've seen your group use is to evaluate applications for public employment or to review performance of a public employee. Probably litigation and public employment are the two that the commission uses the most. People ask, can we travel together? Can we have lunch together? Is that a violation? And yes, you can travel together. And I know the commission does gather sometimes with a quorum or more and have lunch together. The thing you need to remember is when you are together for those occasions, you can't discuss official business of the commission. Even just a discussion of what you might discuss later, it is not allowed. So I would say leave it to sports or the weather or your families or other things, but just don't discuss official business without the public present. So the public is required or allowed to attend all the meetings that are open to the public. You can't require them to register or complete a questionnaire or have any sort of condition on attendance. Public just get to watch. And in 2022, the legislature amended the OPMA to require a public comment section. And so that was added at the beginning of every regular meeting. It's not required in special meetings, only regular meetings. And that was the public comment section that you had earlier this morning, where the public can come and either give an oral comment or a written comment at each regular meeting. So there are provisions in the OPMA to deal with interruptions or disruptions. I think we saw some of this during COVID where there'd be Zoom bombing, or I don't know that the commission saw as much as maybe some other groups did, but there are ways to deal with either in a physical location, you can clear the room, you can mute participants on a remote meeting if things do get out of hand. But there are ways to deal with those disruptions. You can also, clear the room or move the meeting to a different place that would not be accessible by the people who are disrupting the meeting. So there are penalties for violating the OPMA. It would require someone to bring a lawsuit against the commission saying that you violated the OPMA in some way. Maybe you had a meeting that you secret meeting that you didn't notice. So the court can impose a $500 penalty against each individual commissioner. Attorney's fees and any action you take would have been declared null and void. I've not seen the boards and commissions of Department of Health in my time with the AGO for the last 15 or so years have one of these, because I think we're really good about training you and are really good about your staff is very, very diligent in making sure that all notices are sent out and that you are all complying. But again, this is the refresher so that we don't run into those problems. And so this last one is just saying that you're required to have this training and onboarding, but also periodic. And I think we do it more than every 4 years, which is legally required because we like to make sure everybody is aware and remembering. If you have any questions ever about a meeting or whether or not it needs to be open, I would say your first point of contact is Amelia. She's very, very good at all of this. And if she has further questions, she'll get me involved. But please just ask your staff if you have questions about the OPMA, and then you can always reach out to me as well. But generally, I think your first point would be Amelia. But if there's any questions right now, I'm happy to answer them. Otherwise, that's the end of the training.
Well, thanks so much, Heather. I think it's a very useful training for us. And yes, it's good to have it more than every 4 years because our memories don't last for 4 years on this subject. Are there any, I can't see everybody, but if you do have a question for Heather, please feel free to raise your hand or speak out. If not, I think you answered people's questions by your thorough presentation. Thank you so much.
Great. Thank you.
Right. Well, we're gonna change order a little bit. I had some emails through because Dr. Chung, who's chair of the nominating committee, has a plane to catch shortly. Hopefully he's still available. I don't know if he is or isn't. Amelia, do you know if Dr. Chung's still on?
I'm on. Thank you.
Great. You can. This is. You want to just go and do your presentation then?
Yes. So, thank you, everyone. This is Jimmy Chung. I'm past chair and chair of the nominating committee. Last meeting, the nominating committee submitted a slate for the elections of our leadership, Dr. Karen Domino for chair, Dr. Terry Murphy, vice chair, and Ed Lopez, PA, for officer at large. Today, at this meeting, we will hold the official elections. Are there any other nominations from the floor? Okay, seeing none. The, the proposed slate is then accepted by acclamation. So congratulations to Dr. Karen Domino, Dr. Terry Murphy, and Ed Lopez. Mr. Karanen?
Thank you
that,
so
Dr.
much.
Tom.
Yeah.
Oh, okay. I thought somebody had raised a hand. My only comment is that it's unfortunate that we have to hold the elections during a virtual meeting. Traditionally, in the past, we've had it in one of our in-person meetings, and we're able to give people hugs. So, virtual hugs to everybody. Thank you.
Thank you so much. Yeah, virtual hugs. All right. Now we'll move on to new business. Amelia, is this under your discussion? Appointment to the Interstate Medical Licensure Compact Commission, or who is discussing this?
I've got this, Dr. Domino.
Oh, okay, great.
So for the benefit of the commission, including new commission members, the commission has one seat on the Interstate Medical Licensure Compact by statute. In states where the allopathic and osteopathic boards are separate, each gets one. The executive director has historically been the commission's representative to IMLC. I have continued that after Melanie retired last year. But in an effort kind of at good governance, I'm bringing it back for your consideration. I did talk to the executive committee earlier this week. In brief, the IMLCC, so the Interstate Medical Licensure Compact Commission, meets twice a year. There is committee work that's assigned. I won't say it's the most substantial part of my job in terms of what I've been doing, but basically it's a much larger group, not entirely unlike this group. It's just dedicated to the performance of the compact and making sure that the compact is financially solvent, making sure that the standards and rules are clear. As it was being stood up, it was a fair amount of work. And as the commission came on board, it was a fair amount of work. But these days, it's basically about 2 hours a month. And then, as I mentioned, periodic other meetings. There are two big meetings each year, one of which is virtual and one of which is in person. I've been doing this for the commission since I took over from Melanie, and I'm happy to continue that. But it is a point where we should probably check in and make sure that if you have questions or that I can answer and address, I'm happy to do that now. As I mentioned, the executive committee would like me to continue doing this, but it does require a full vote of the commission. So I'll stop there and ask if any commission members have questions.
Well, I don't see any questions. Do we need to have a motion then to appoint you to this thing and a second of the motion? Is that correct?
Heather, I think that's correct, but I'll rely on your input here.
Yeah, that's correct.
So moved.
Okay, good. Do we have a second?
Second.
Okay, any further discussion? All right, all in favor, raise your hand or say aye.
Aye.
Anyone opposed? Hearing none? That's your job then. Add that to your list. It's already been on it, so thanks for doing that. And
Thanks,
will you
Dr.
also talk about the appointment to the Physician Assistant Licensure Compact Commission?
I will. So I think the commission is aware that what was done for interstate licensing of MDs and DOs has now been started for PAs. The model is slightly different in terms of the way that it works on a technical basis. But the idea is similar, that there will be a PA compact and a commission that supports it and writes rules for licensure, reciprocity, all those sorts of very detailed, very technical issues. This is a little bit unusual because it's just being stood up. So unlike IMLCC that's been in place for several years, I think the IMLC came in 2017 and Washington's been a part of it since 2019. The PA Compact is coming online. I've also talked with the executive committee as well as Micah. Obviously, Micah has a detailed understanding of kind of how licensing works. And we have a recommendation for the commission to consider. We're recommending Marissa Courtney, who is our licensing manager. I know many of you have worked with Marissa on Panel L. As we get started with this, the combination of the fine points of the licensing statutes and our rules, as well as the oncoming system, our database change over to Helms, Micah and I felt very strongly that Marissa's in the best position to understand the fine points of the legislation. She's also at a point where she has some bandwidth to be able to participate in this as it gets stood up. So our recommendation to the commission on this is to appoint Marissa Courtney, who is our licensing manager, to on behalf of Washington to the PA Licensure Compact Commission.
And also the executive committee did approve that suggestion. Is that correct? Yes. So
yes.
Do we have any questions for Kyle or any comments about this? Okay. Can I entertain a motion for this appointment?
For Ms. Courtney to represent us.
Second.
Great. Any further discussion? All right. All in favor, raise your hand or say aye.
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 Anyone opposed? All right. Well, she's appointed. Wonderful.
Thank you so much,
Thanks
everybody.
so much. So the next one deals with grant funding process for the IMG Assistance Program. Mr. Micah Matthews.
Good morning, Commissioners. So on this one, a little bit with the next item, and then an item in policy, we're going to be getting into the historical weeds. So I understand if there's some lack of knowledge because it's been spread over 5 years as part of a legislative directive. But so what you have in your packet before you, if you've reviewed it, is something that's been directed that the IMG work group look at and make a recommendation to the Medical Commission for adoption. It's a little bit of confusion because the process that we have to use for grant disbursement, as described under 6551, Senate Bill from 2020, is that we use the DOH grant process. So really what this was we mapped out what the DOH grant process is that we have to use because all the grant funding will go through them. But we also tagged on a little bit of steps to make it clear what the Medical Commission's role would be, at least as far as staff is concerned. So this is purely a process adoption. There's not a real ability to wordsmith this because it's not our process, but we're committing to using it. And out of an abundance of caution, we're asking for the commission to approve this process. With respect to selection criteria, that will be developed at a future date. How this plays out is the legislation directed that the Medical Commission adopt a grant process, and then there would be grant funding should it be appropriated by the legislature for things like pre-licensure navigation or career navigation. So that can be anything from subsidizing a clinical experience for a licensee. It can be helping them complete ECFMG or USMLE. It can be related to funding a IMG advocacy group to help educate clinics or match applicants with clinics. So there's a myriad of things that this could be used for, but again, the selection criteria is not what's up for approval right now. That will be developed with input from the medical commission, the work group, and the various stakeholders who potentially could be subject to that. So this is just an approval request for the process itself, and it would take a motion and a second. Any questions?
Well, I don't see any questions or hear any questions. So can I have a motion to initiate this process?
So moved.
A second. Any further discussion? All those in favor, raise your hand or say
Mr.
aye.
Lopez has his hand up,
Oh.
Dr. Domino.
Oh, you do? Okay, sorry, I didn't see you there. You're sort of in.
Yeah, hi.
Yeah.
Good morning, Mr. Matthews. So my only question is, does this process include the who and the how of the acceptance process?
As far as who would be selected, or?
Correct. The selection process. Is that included in this process?
To some degree, as I said, the selection criteria is not part of this. This is purely
Right.
how the grant disbursement gets processed internally.
Okay. All right. Thank you.
No problem.
Any other comments or things? Again, I don't see everybody, so please yell out. I only see a few people, especially with the big screen of what was presented. All right. Well, all in favor, say aye.
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 Anyone opposed? Say aye. Okay, that is approved.
All right, moving right along. So this is the 2025 legislative agenda. We've got a number of new commissioners, so I will go ahead and explain a little bit of how this works, and then I'm going to give a political outlook just to help inform some of what we're looking at. So historically, the commission approves the concepts of a legislative proposal for a given year. I have to have that approval before I can start working with stakeholders developing language. Some language is already developed because there were some interactions with the International Medical Graduate Work Group, and so they made some recommendations. So what you have before you are 5 items that need your approval to go forward with development, and then 3 items that are for your information. The for your information items come from the International Medical Graduate Work Group, and the report that they have submitted to the governor's office for review and approval before it goes to the legislature. Should the legislature decide to take them up on those recommendations, the anticipation is that it would be brought forward by a legislator and not necessarily the medical commission. The one exception to that could be the clinical experience license, but at this point, I'm unclear whether there's going to be an interest by a legislator to do that. So with that being said, that's the process, and once you give an approval, we will work with stakeholders, meet with legislators, and develop language. It would then be submitted to the governor's office as a proposal, otherwise known as request legislation or agency request legislation, in September, and then with any luck, we might hear something about it in December. So otherwise, it's sometimes January. So that cuts it close, but that's what's happened in the past. So going to the political outlook piece, I do want to just note a couple of things, because there are some items that, while I don't want to say they're extremely controversial, they may or may not be received well. And even in the for your information section, there was some information that came out last week as well as today on a couple of news stories that you need to be aware of. So with the federal outlook, I'm not going to weigh into the politics, but as a political operative, I can't ignore these things. So there's a lot of confusion, obviously, on the federal side that may or may not stem from impacts of the Chevron ruling or the federal presidential election and anything that might impact down ticket races. The reason I bring this up is because with a lot of activity on the federal level, it can tend to distract what our state level legislators are looking at. We saw this in the extreme and in the post-Dobbs ruling from the Supreme Court, where while they considered a lot of policy ideas, the focus really was on protecting reproductive rights and gender-affirming care. That was an extreme focus for about 2 legislative sessions. Without being able to see the future, I don't know exactly what's going to occur, but I can anticipate that there will be some focus on that as opposed to the state-based programs. With respect to the state outlook, I don't think for a minute that the election on the state level has a predetermined outcome. I'm unsure based off of the polls that I see and based off of the grassroots support what the governor's office is going to look like. That could have a significant impact on what ends up going forward in our request legislation. It also could have a significant impact on commission appointments. So I wanted to make sure you're aware of that. As of this morning, we've got a couple of budgetary cautions. The governor's office did issue guidance to state agencies, basically saying do not start new programs. Don't ask for more money beyond just maintenance and operation of existing programs. That doesn't necessarily impact what I'm asking you to approve. It absolutely impacts what the International Medical Graduate Work Group requested, because there are 2 program expansions that are in there, or actually 1 new and 1 expansion. So with that being said, it could be that we get some of our items shut down because of concerns about budget. There's also, if you're not familiar, 3 initiatives, which should they be approved, will cost the state billions in revenue. And so there will be certainly a budget shortfall and probably a budget fight to figure out how to fix that. So with that being said, we'll go into the approval pieces. The first one is fairly simple. When a new profession gets passed, there's supposed to be a reference to the home of that profession, in this case, the Medical Practice Act or the PA Practice Act, and it's supposed to be added to the Uniform Disciplinary Act. So when people reference the professions list, which is 18.130.040, all of these things can be considered. So an example is the Uniform Telehealth Act that was passed this session refers to that section, but unfortunately, the medical license compact is not listed as a license type or a profession type. So technically, the telehealth law doesn't quite apply. We think that there's intent that it does, but this is just a technical fix to make sure that the compact statute is added. And should the CAA or the PA compact statute not have been added, we would be adding those as well. So that's a technical fix. I'm going to go ahead and ask Dr. Domino, do you want to do a group approval, or do you want to approve item by item?
Do you think it's better to do item by item? Maybe it is. I mean,
I'll defer
it's really
to you.
up to you.
I can go either way.
Is anything super controversial from what I saw here? It didn't seem like it, but why don't we'll take a few more minutes and that. Any questions about this thing? I know our memories are often short, so, and
Sure.
It's complicated. Any questions or discussion? Can I entertain a motion to approve this?
Motion to approve the Uniform Disciplinary Act technical amendment.
Second. Good. I see a lot of seconds. Any further discussion? All in favor, say aye. Aye. Raise your hand. Anyone opposed? Okay, good.
Thank you very much.
That passes.
The next thing is a historical request that the commission has had, and that is the ability for lack of a better term, to go out gracefully. And so this would create a process by which someone could yield their license back to the commission in a non-disciplinary way, because currently your only way to do that is through a STID or an agreed order, and that is obviously a mark on the end of your career with Washington State. So long, the idea is, so long as you are not under active investigation or under discipline, you would have the ability to yield your license back and yield that property right back. Importantly, that's a big piece of this. And so that is the concept that we're working together. I'm working with Mr. Farrell to line out language that the commission would feel appropriate and be able to enforce. So with that, I'll turn it over for a vote or discussion.
Yeah, I just had a question. So are these people, say for instance, you decide you just want to, you retired and you don't want to have any sort, you can just retire. Is that right? And get rid of your license and not have it affect you?
Right. So there's a couple of contingencies here. So as Mr. Glein has told you on a number of occasions, just because your license expires doesn't mean the commission doesn't mean that, number one, you don't still have the property right because you can reactivate it. Number two, it doesn't mean that the commission doesn't still have authority over that license. So that's why sometimes when you see an expired license complaint come through, depending on the nature of it, you will still open it for investigation and pursue whatever was going on. So obviously that wouldn't be the case in this particular proposal, as it has to be non-disciplinary. Kyle?
I just wanted to add, Dr. Domino, this is Micah and I and Mike Farrell have worked on this partly as a result of the letter that we got with regard to folks who have an active license, but they may be at a point where they're having physical or cognitive issues that are preventing them from practicing, and to the point where they may not be safe to practice, but they don't necessarily want to go through the I'll say stigma, have the stigma of having, a formal order with the commission on their record. So again, we're being very careful with this. I think that this is a serious ask, and I think it goes to kind of the dignity specifically of those folks who are in a later stage of their career, who have reached a point where they don't want to practice anymore, but this allows them to kind of disentangle themselves from the commission's jurisdiction in a clean way that doesn't involve litigation. I'd strongly support this.
Yeah, put another way, I would say this is introducing human-centered design in a further aspect of the commission's work.
I would like to say that I really appreciate the intent of this act and this idea. And it has been, my only concern was in the event of someone who knows that there is some litigation coming their way, or they know there's a disciplinary judgment coming their way and we don't know about it yet, that they go ahead further and say, oh, you know what, I'm going to go ahead and get rid of my license now. But that has been addressed, and I feel confident that we can deal with that later. But I thank you for putting this together.
Thank you.
Any other comments? And again, I can't see very many of you. Please speak out or raise your hand or. Okay. Well, then if no other comments or questions, can I entertain a motion for approval?
So move.
And a second?
Second.
I do see a second, several seconds. All right. All in favor, say aye.
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 Raise your hand. Anyone opposed? Yeah. Okay, it's passed. Thank you.
All right. Thank you. Moving right along to the locums limited license. So this is generated out of some feedback from stakeholders as well as our licensing unit. The principle here is a few years back, the military spouse licensure expediting laws, a number of them got passed. And the principle here is accepting an initial bolus, I guess, of documentation and issuing the license contingent on the remaining documentation being acceptable. And so that's what is happening right now. They sign an attestation as a military spouse that the information that's coming that takes a little bit longer is going to be within the accepted parameters that we described in the application. They attest to that. They also attest to the fact that if it's not as they represent, they are giving up their property right, and we have the ability to revoke the license. So the same principle is around the design of this locums limited license. The Washington Association of Medical Staff Specialists are especially excited about this concept. The idea being that it would be a one-time, time-limited license that would be issued on reduced documentation, with the understanding that the documentation needed would be coming a little bit later. This would allow for locums folks to get plugged in faster. And again, it's stakeholder and licensing unit feedback that has generated this concept. Any discussion?
I do see Terry's hand up, so you're one of the few people I can see.
Okay, thank you. I do have one question, and that is there precedence for this in other states, and what has been their experience?
There are other states with locums licenses. I don't have feedback as to what their experience is, other than the fact that these pathways exist. One of the reasons for considering this as a pathway specifically is it would be long enough to where they could get placement here, and then if they thought they were going to stay later, they would have enough time to get a traditional license. And frankly, I'm not sure what the uptake is going to be on this, given the fact that we have the medical licensure compact and the PA compact soon to be coming. However, California and Oregon are two neighbors that we share the most licensees with, are not part of those compacts. And if discussions with them are any indication, they're not joining anytime soon. So this would be a way to attract border state as well as a larger state locums placements if needed.
So we don't have any information if there's any downside or potential pitfall to this?
The information we have is, again, based on our personal experience with the military spouse application process. So we have seen that play out for the past, I believe, 3 or 4 years. There has not been an issue in our experience with that, aside from the military spouses failing to indicate that they are military spouses, so we can give them that white glove expedited treatment. Beyond that, the process seems to work, which is why we're drafting this relying on that model of a process.
Okay, thank you.
Mr. Lopez, I can see you now.
Oh, thank you. I was just thinking, in the event of a pandemic again, this would be very helpful, I think, to expedite the process to get staff if that ever happens again or something similar. So I think this has some degree of value.
I would agree. I think that if we're in a full-blown pandemic, the likelihood of this being used as opposed to the Volunteer Healthcare Practitioner Act, we would probably defer to that. We, as I've said to some of you, we validated 9,000 people through that act, MDs and PAs, all on our own. The number that DOH validated, I'm sure, dwarfs that. But between that, this locums thing, compacts, and the fact that we are quite rapid with respect to issuing our own traditional licenses, I think we will be covered in any eventuality.
Any other questions or comments? Again, only see a few people, so speak out if you do. If not, can I have a motion to approve this?
Motion to approve.
Second?
Second.
Several seconds there. All right, all in favor, raise your hand or say aye.
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 Aye. Anyone opposed to this? All right, this passes as well. All right, move on to the next one.
The next one's fun. So if you've been on the commission longer than, say, 5 years, you have had some experience with complaints relating to medical examiners. When we first got these complaints, there was a lot of internal discussion about what is our authority here, what role can we play, and much of it stems around the fact that if you read the description of a patient in the Uniform Disciplinary Act, it seems to imply that they're alive. Obviously, that's not the case with medical examiners and complaints relating to them. There's also a pretty big question mark around what do we have the ability to do, and that comes with requesting or mandating changes of cause or nature or determination of death. That is pretty much, we've determined, is off the table for our authority. But it doesn't solve the issue that we have seen come up again and again with respect to people complaining about medical examiner issues. We've even gone to a hearing on a medical examiner issue, I believe it was last year. And so the proposal here is to make the authority clear by taking it away from the medical commission. So any cause or manner of death determinations would be litigated within the court system, supplemented by the ability of the judge to appoint a special master, i.e. a medical examiner, who could really get into the weeds about what is going on and provide expertise. So that is the proposal. We had this drafted a few years back and had someone on the line to be the sponsor, and then they lost their election. And so we thought maybe we were past all that, but this year we've received a number of medical examiner related complaints, so it's still an issue.
Yeah, I think it's, I just say I've been on the commission for a number of years, and it does come up. And I think a lot of it is, disagreement with the diagnosis of the death, the cause of the death, and the fact that that cause may make it so that the heirs don't get any settlement or anything, any money that may come from things. And so I certainly myself would be in favor of removing it from our decision making, because we're not really, and I'm glad to hear it doesn't apply to what we're supposed to be doing with the Uniform Disciplinary Act. Mr. Lopez, did you have your hand up briefly?
Yeah, so well, I think it's a great idea, but my concern is, does that mean then that the MEs have no regulatory or supervisory body?
No.
Who regulates them and who directs them?
Right. So they would still have a license. So there's still that property right and that responsibility that we would have. But when it comes to debating their cause, manner of death determination, what goes on the death certificate, that gets shunted over to the court.
Okay.
And so
it has to do with this topic in particular.
Yeah, I mean, if they were abusive to family members, if there was some sort of a sexual misconduct with a key third party, obviously not the decedent, but maybe a family member or something like that, the sexual misconduct rules would still apply. And so you've got a number of things that they still are responsible to do. The professional standards are largely for them determined by the policies and ethical statements of the AMA, as well as the National Medical Examiner group. And there's a state level one, which is called WACME, and they are fully aware of the irony of that name. But yeah, so that's the ask on this one.
Okay, thank you.
Any other questions? Again, please feel free to speak out. All right, hearing none, can I have a motion to approve this measure?
So move.
Second? Yep, good. We have a second as well. All in favor, raise your hand or say aye. Aye.
Aye.
Anyone opposed? Okay, that passes as well. All right. Last.
And on
item.
to the final approval before we get into more of a discussion about the for information things. I'm going to go ahead and say up front, this is the one that I am most skeptical about its success, but it's also the one that I probably believe in the most. The Public Records Act, as it says, came into being in the 1970s. It's for by and large, in my opinion, it is a good piece of legislation and good policy. So the state policy is everything should be open with very, very few exceptions. There's also a Sunshine Committee that we have regularly started participating in that evaluates exemptions to the Public Records Act. And so far, we've got 2 years in a row where we are testifying in favor of retaining certain public records exemptions, things like, medical and health history, WPHP records, and that sort of thing. What we're dealing with now is since 2011, we have collected demographic information on our licensees, and we've got a very decent store of it, and we use it in workforce planning. One example is most recently we got a surge of MDs during our busy season, which should have been limited licenses, but we got around 350 more than anticipated MDs applying. Obviously, that made us scratch our heads, and we went to our demographics to figure out if there was a rhyme or a reason. We're still looking at that. It doesn't appear to be at this point. It just seems that we just got a surge, which is fine. But the issue here is that 2 years ago, the Department of Health passed companion legislation, I'll call it, which authorized them to collect demographic information on all of their professions. So while good for workforce planning, it does present some concerns. And so I will say that in order to get certain aspects of licensee data out, there are currently 3 pathways. The first is what you see regularly at your business meetings, which is the lists and labels request. That's just for professional associations or educational institutions that are approved by you. The second is the Public Records Act, where if you make a request, you can get detailed information minus certain what we call PII, or personally identifiable information. So that'd be social security number, home address, home phone number. And in our experience, the application of this is imperfect. We have had scenarios where practitioners' home address have been released to what could charitably be called hostile organizations. And the argument that was given to us was the application that had the home address was over 10 years old. How are we to know that it was still their home address? And obviously, we were pretty distressed by that as an organization, getting that information getting released. But when you combine all of this with the demographic and practice information that we have that's not considered PII, and you consider that in the 1970s, there were not large language analysis models. There were not huge data sets available for purchase on the dark web. These were not considerations in 1970. And so at this point, even if this particular piece of proposed legislation goes down in flames, it's a discussion that needs to be had, because there is an absolute safety issue that I'm raising to you now with respect to the ability of an individual, regardless of their intent, getting so much information in such a broad request on so many of our licensees, and then combining it with other data sets. So the ask here is that there would be 2 things: a wholesale prohibition on releasing licensee information, demographics, and that sort of thing, and also a prohibition on any medical records being released through the Public Records Act from our agency. The reasoning behind the second ask is because we don't generate those records. Someone else does. We get them second or third hand. And so the appropriate place for the patient or anybody else to get them is there. And we have seen time and time again that the public records suppliers don't have the constant or consistent ability to either redact or identify what is a patient record and who they should be going to. They do have a process that says the person or the guardian that is the records are about may ask and receive them, so long as they sign a form or an attestation. Again, it's an imperfect application and mistakes do happen. So that's the concept. That's the idea. It does go against the existing state policy somewhat, and I do anticipate a number of folks opposing the concept just based off of principle. To answer a question, is it possible to get our data another way? Absolutely. And that is through the format of data sharing agreements that are reviewed, crafted, and fulfilled by staff. The reason I am such in favor of those is because, number one, we're allowed to evaluate the requester. And number two, there are clawback provisions should they be irresponsible with the data in a way that's not consistent with the approved data sharing agreement. So with that, I'll open it for discussion and hopefully a vote.
Dr. Curry. And then second, Mr. Lopez.
Thank you, Micah, for doing this. I just want to say that there was a friend of mine who was an OBGYN who had a patient find out their home address, follow them home because they were very upset, as you can imagine, sometimes happens in OB cases, and they shot the doctor as they got out of their car at their house. So it is a really kind of a fear, I think, and a concern. So thank you very much for bringing this forward.
Very sorry to hear that. And that's exactly in a post-ops era what we're trying to avoid.
Mr. Lopez, I saw you.
Yes, I'd like to, thank you, Madam Chair. I'd like to echo that sentiment as a potential victim of a similar incident myself, serving on the commission from an unfavorable decision made by the commission. I was singled out and information was obtained in some format regarding my home addresses and other personal information. So I think, you know, there used to be a time in the 70s, we talk about the 70s, where respect and honor and safety and compassion was a very different way of in America. And today it appears that going after people seems to be a wholesale process anymore. So I certainly think that if there's anything we can do to protect not just the public, but protect those men and women who every day put themselves out there to try to provide good care and or make tough decisions, I think is certainly worthwhile. So thank you, and I really support this.
Thank you, Mr. Lopez. And I think if this gets approved, I absolutely am going to want to talk to you further about that and understand the nature and the details.
And any other comments or questions? Please yell out. I only see 5 people. Okay, well, all in favor. Can I have a motion in favor of this?
So move.
Second. Hey, all in favor, say aye. Raise your hand. Anyone opposed? Ah, there's even a clap on there on the Zoom meeting. All right. Well, I'm glad we took them all separately. I thought it might be too much to do with them all at once and that. So we'll move on. Now the next thing is the 2025 meeting dates. They
I'm sorry,
appeared.
Dr. Domino, we've got 3 things to discuss. I need to make sure that the commission's aware of these things coming forward.
Oh, okay. Sorry, I didn't see them there.
Yeah, so this is on the same page. So I just wanted to make the commission aware of what some things are being done that will impact some of your work, maybe not with the commission, but in your professional lives. So the first thing is there are a number of recommendations that the IMG work group made in the report, and I'm highlighting 3. So the first is updating your clinical experience license for a number of reasons. We're making that the center of the IMG pathways to get licensed. And so it has already been established. We've seen that almost to the last, the IMGs who use that license are in rural areas. The issues that we're running into are, number one, the American Board of General Practice has a 4-year curriculum that, should you complete it, it will allow you to take their board certification, which addresses an issue that I'll get to a little bit later, Dr. Domino spoke to earlier. So the changes would be removing the Washington State residency requirement of 12 months. That was always a little bit problematic in verification, and frankly, we don't do it for anything else. Number 2, removing step 3 as a requirement from the law. That just aligns it with the ECFMG process. So you do step 1 and 2, and then ideally, if they get matched into a residency, or if they do that board process that we'll talk about later, they can take the USMLE step 3 prior to that, and they will have completed that. So there's not a risk there. The third thing is to increase the amount of time that the license is valid for from 4 years to 8 years. There's a couple of reasons for that, but the primary one is in talking with medical groups who have used this license, they've had to dismiss a couple of folks because when taking into consideration the remediation timeframes, they wouldn't complete the 4-year curricula in time, and so they had to be dismissed from the program. So allowing that to happen, but also making it longer for people who are trying to match into a residency, or in the second item, using the clinical experience license as part of their residency transition period. And so that's the next piece that I'm going to speak to. So the other piece is the NRMP, or National Residency Matching Program. The work group, members of the work group, are submitting a letter asking for an innovation waiver for the state. So from the all-in policy of NRMP. The reason being, we are looking at asking the legislature, and this is one of those new program things that may be on the chopping block, for state-based funding for residency positions, up to, I believe, $5 million is what the request is. And so what would happen is you would be, as an IMG, use that first year as a transition year under the clinical experience license. And if you are successful through that, you would matriculate into the final 3 years of the residency. The transition year is something that the NRMP thinks is pretty innovative. It also addresses a big concern that the program directors have raised about the ability for them to know what the skill set is on the IMG that they're accepting into the program. This is one of those grant scenarios that we were talking about, where should the legislature appropriate the money, the medical commission, through developing criteria with stakeholders, would be the ones who would be selecting the programs that would receive the funding for on a 4-year basis, and then the DOH would disperse the funding. And finally, this is the third prong of the pathway, I guess is what I would say. So the first one is clinical experience to a traditional residency match, which we've seen and has been happening with that. The second that I just talked about is the dedicated IMG residency positions that are outside of the match. And the third is an apprenticeship pathway. And so the concept there is you do 4 years minimum of supervised practice on the clinical experience license. You complete the 4-year curricula, and you take USMLE Step 3, and you take the boards for AAGP, or you can be board eligible and take an ABMS board if it's available to you. I will say, just a side note, I think ABMS is working towards this on a board-by-board basis. They're becoming more and more creative with respect to IMGs and how to get them integrated. So at the end result, you would have 4 years of supervised practice. You would have someone who is board certified, so they would be able to get credentialed in a hospital. They would be able to have insurance billing rights. They would be able to participate in those third-party billing systems, and you would have an evaluation process during that. So those are the 3 pathways. The other piece that I will raise that is being discussed or proposed is, if there's someone who is exceptionally qualified, there would be an abbreviated evaluation process. So 6 to 8 weeks of supervised precepting or something like that. This is something that I am not ashamed that we're stealing from Canada. And it was a topic of discussion at that DC symposium about how they were addressing IMG issues. And the final thing in that legislation would be the LCME, which is the Liaison Committee for Medical Education, is stopping their accreditation, their dual accreditation of Canadian medical schools, July 1, 2025. That will shunt Canadian graduates into a full IMG status, whereas before they've been recognized almost the same as domestic. And so the change in the law that we propose to go along with this is to recognize Canadian medical schools and exams as equivalent. So that is the 4-year information. If there's any questions, or if you have any concerns or want to talk, I'm available via email, or I'm happy to meet with you to go through it. I realize this is a very brief overview of effectively 5 years of work. So thank you for that.
So this is a report. We don't need to take any action on the report. Is that correct?
Just for your information.
Okay. One of the things as an academic physician, we have a lot of students who don't match into a residency program, who are U.S. grads from like University of Washington. And it's hard to create these residency spots. Part of it is, it depends what area you wish to go into. I mean, we have a lot of our programs have thousands of applicants who are known and have well qualified, and many of us do take exceptional international residents, like as well into our programs. So how do you deal with the absence of enough slots in the United States to train all of the people coming out of medical school here, as well as these people?
Right. Well, one of the proposals on specifically on the IMG residency positions is that there would be a threshold before you were allowed access to that, and that would be not matching through one cycle. And so if you didn't match that first year, you would be eligible to at least apply to these programs and talk to them. It's outside of the match process, so there's a bit more engagement between the program and the IMG. And recognizing that that is not going to fulfill all the needs of IMGs that we have, that is why the apprenticeship pathway is being proposed. And while at the time we proposed it, I thought it was kind of not extreme, but outside of what folks were really talking about. I mean, there's talk about a 9 or a 10-year supervised practice process. Once we went to that symposia and in DC, Dr. Domino, it became clear that everyone was kind of thinking along the same lines, except the organizations that stood to benefit from not doing this. And so that's kind of where it landed. I will say I was surprised that the IMG work group approved unanimously to propose the apprenticeship pathway. I thought there was going to be a lot more discussion and concern, but they seemed fine with it.
Yeah, and it sounds like primarily to be able to train people in family practice and to work in areas of our state where we need people, not to be in Seattle and Spokane and Tri-Cities and other major centers, right? Yeah.
Yeah, it's family medicine, internal medicine, psych, and peds at a minimum. It's the including but not limited to language that we're putting out there. So it could be for other specialties. Certainly, there's not a requirement that they go to a rural area. That's typically very difficult and expensive to enforce, or at least make sure there's compliance. But we have residency spots all over, positions or programs all over the state that would be interested in adding state-based slot funding, especially if it's outside the match.
Great. Thanks so much. Anyone have any questions or comments? All right, so no vote is needed. And now we'll move on to the 2025 meeting dates. Who would like to mention this? Amelia, did you put this together? Kyle?
Yeah, I can certainly talk about it, Dr. Domino. So there was a general consensus, I think, among commission members that the meeting revision that we did last year wasn't necessarily working as well as we hoped. Just remember, we moved business meetings like this to a completely virtual environment. And then we also consolidated the case reviews and personal appearances down into a single day, but we were doing them more often because we were consolidating the schedule. We got a fair amount of feedback from both staff and commission members that in general it wasn't working very well. So the executive committee, as well as myself and the staff, came together and thought that maybe we could figure some sort of happy medium between the two. There's a recognition that certainly for earlier or mid-career physicians and PAs that having a 2-day meeting cycle can be difficult to accommodate us if you're active clinically, to say nothing of the folks who are, in high demand as physicians or PAs who are in later stages of their career with a great amount of experience and or teaching responsibilities. So we are bringing this back to you for proposal. The grid that you see before you kind of outlines how we'll do this. There are a couple things. There are a couple kind of just general notes down at the bottom. Again, we came together with the executive committee and we're putting this out there for your review as a whole. I think based on caseload and workload on the staff side, we can make this work. You'll see that there are still virtual mixed in with in-person, but there was also a sense, and Dr. Domino, Dr. Murphy, I'm happy to let you guys talk about this, but there was also a sense that since we had moved to a majority virtual, that there was a loss of kind of connectivity and collegiality and time between the commission members themselves. So because our schedule was so condensed, you didn't have time to sit down and have lunch together because we were almost always having to work through lunch. And I think Dr. Domino, you in particular also were really supportive of the idea of bringing back lunch and learns in some way, shape, or form. So we've tried to balance this with those sorts of principles in mind. I will note that December, January, and February, because of the potential difficulties with travel during the winter, are either we're either not meeting or we are doing it virtually. And then we will be moving back to some in-person business meetings mixed in on a 2-day cycle as well. Dr. Gallinger had also proposed having the retreat and SMART training kind of be grouped together and alternate between essentially CTAC, but the Seattle side of the state and Spokane. So this is the option that the executive committee has endorsed. But we need a vote, at least certainly for the business meetings. The rest of it is there really for informational purposes for you all. So I hope that lays the context for why we're coming back to talk to you guys about this. I'll leave it to Dr. Murphy or Dr. Domino to talk maybe more in depth if you'd like.
Well, I'm happy to take questions. I see Dr. Curry.
Hi, thanks. I'm certain the executive committee already thought about this and there's a reason for it, but I was just wondering when I looked at it, July and August have in-person, which is a time when most people travel and take vacation and families get together and stuff. So I just wanted to propose or ask you if you'd thought about maybe moving one of those to virtual and instead of October being virtual, make October in person and maybe not make November in person, only because also everyone travels, well, frequently to get together with families for Thanksgiving. So it'd be great if November was virtual because then you're not sort of taking time off twice for that month. So just thinking about that as those are my comments. Thanks.
Yeah, I think that a lot of it was trying to have enough regular in-person meetings just for the camaraderie, getting to know staff, getting to know people on your other panel, right? Which recently, even in our in-person meetings, we haven't had a room where we can get to know people over lunch and to be able to have some educational opportunities over the lunchtime, which are relevant to us. But I know I personally, and I'm not sure if anyone who was on that had any particular concerns over the months. It was, I think, the one that was expressed the most was travel in the winter. Also, I note that I will be away. I mean, I looked at my old schedule, and in December of late November of 2025, I'm gone. That's okay. I mean, I know it's hard to do, but I don't know what anyone. Do you want to think about this and figure out which time is better to have virtual? I mean, there are also a lot of professional meetings in October as well. So, there's that October is a huge travel time too for a lot of people.
Dr. Domino, can I'm absolutely open to what Dr. Curry's talking about. I think that makes sense. Again, we're trying to, it's like the world's most complicated Tetris puzzle, trying to put something like this together. And but we are trying to again make a certainly address the concerns that have come from various commission members. But in terms of today, if it's possible, if we can just get a vote on the dates, that will be enough. And if we need to change format from virtual to in person or vice versa, we can certainly do that. I'm happy to circulate a kind of second round of the virtual versus in person, but the dates are really important for us to not only find venue, but also make the required filings with the code register. It also allows staff to kind of plan other activities around that calendar. So if we can get a vote on the dates, I'd really appreciate it. With, again, a nod toward the concerns that Dr. Curry brought up with regard to virtual versus in person.
Yeah, the other thing is I wanted to mention, because I also see Claire there and I'll comment in a moment, or call on her in a moment, but we also talked about the real importance for those who cannot attend the meeting and can do virtual presentations on a in-person meeting to have better IT systems so that the experience is better for all of us. And that. Claire, I see or Kyle, you want to make comments
about
about
that? If I can
that?
just really quickly, just a note of assurance for the rest of the commission. We have purchased the hardware. We're going to use Owls. It's similar to what I used for the executive committee meeting, and I think Amelia's used it a couple times for policy. We have the latest version of Owls. They will be up and running in the September meeting that's in person that's coming up. So you guys will have a trial run with that. We've done a bunch of work in the background to address mainly the audio. For sure, the audio needs to improve. We've gotten that message loud and clear. We have purchased the requisite hardware. It is on its way as we speak.
Great, thank you. Claire.
Yeah, I think you're talking about what I wanted to talk about. For those of us who really have to attend more virtually, it'd be wonderful to be able to be present for the whole meeting in a virtual way. It like a combination team meeting and in person. I don't know why we can't have a screen so that we can see and talk and be seen for all the cases. Now we just can call in for our cases with very bad audio, and it's very hard to hear. I don't know if there is an IT way to combine it, but that would be greatly appreciated.
Dr. Trescott, there is, and again, in September, that is going to be our first trial run with the additional technology. So assistance and support is on the way.
As far as the dates, are these don't intersect? I know we had some changes this year due to like Juneteenth or something, and the attorneys needed to work that couldn't, because everyone has off that day. Were those all covered well, so that we don't have to come back and make changes?
Legal has signed off on this. Compliance has signed off on this. Amelia has signed off on this. So really, the powers that be are all on board with these dates and this approach.
And then, does anyone else have any comments or questions about it? Again, please yell out or something. I can't see you. And I must say, it's very hard to run a business meeting with a computer that is, I'm on even the commission computer, so maybe it's 1 foot by 7 inches, of which in my screen, and maybe it's my ignorance, by my setup to see myself and 8 people. So unless I go to different pages. So I think for the business experience, committee experience, it'd be better for all of us. And we'll get to know each other a little more than we do by being in our separate panels and having very little interaction in that. Right. The only other comment
Karen, if I could just say, we polled panels, we polled committees, we polled everybody, and the old format was not working pretty universally. And so this was our best attempt to improve it. And if we could just vote on the dates, consider this a trial. And we're sensitive to whatever anybody has to say, knowing that, you know, we're all experienced and nothing's going to be tailored exactly for you. But that's the nature of a group, you know, a big group coming together. But you know, there's been a lot of work put into this so far, and so everybody agreed on the executive committee that, you know, this looks like an improvement. So if we could
And let
just
me
vote
just
on the
say,
dates.
yeah, I'd like the commission, or, you know, to be, you know, a little more relaxed about people missing meetings, because a lot of us do plan quite far in advance, and we're talking about changes that will be occurring in the next year and a half. I had always looked at, you know, just that it does hit us all. We have weddings, we have big events, we have other things that we may plan to be away around. And then there's this schedule. So I think for staff, you can appreciate we'd appreciate your flexibility if we can't make a meeting. Claire, you.
Yeah, I want to know if we could consider some action on the suggestion that Dr. Curry made. July and August, I agree, can be difficult times for people to be present. And are we going to consider that in our scheduling?
I'm not.
So
I don't know.
Claire,
I don't think we need to. Do we have to deal with that now?
No, you're
Claire,
only voting on the dates today. Everything else can change in the future. It's just the dates.
Thank you.
I just wanted to say, I know you guys know this, but the November meeting is exactly 1 week before Thanksgiving. So that means people that work are going to be taking time off like that week and the next week. I don't know about other people, but as a surgeon, like the week before Thanksgiving was always one of my most busy weeks of the year, because everyone wanted their surgeries so they could use some of their like Thanksgiving vacation for recovery. So and I noticed it is 6 weeks, I think, after the October meeting. So I just was wondering if that was intentional, or if it might be better to move it up 1 week to mid-November.
So
to just separate
November is impossible. That is literally the only week we can have that meeting in November.
Then just ignore me. Ignore me.
Sorry. We do
No
try to
worries.
work around it, but that month is the worst, I have to say.
So again, if you can't make it, I won't be there myself. That's okay. You know.
Okay, I make a
people
motion
do
to
travel
approve.
at that time. Yeah.
I make a motion to approve the dates and discuss format and stuff later.
Okay.
Second.
Is there a
Amelia,
second?
can I have discussion?
Yeah, you can discuss.
I'll second it, but I want to ask Amelia something.
Sure.
Amelia, why is November impossible? Why couldn't we move it up a week? What is the barrier?
So the week before, hold on, I gotta pull up this calendar. So there's an FSMB board attorney workshop that will be likely the 6th and 7th. The week before, there's Veterans Day, and we don't schedule meetings during a week where there's a holiday, because that causes a lot of issues for the staff. So, and then obviously the week after is Thanksgiving. So these are literally the only dates. That week is the only week, unless we make it a whole other day, the first week in November. But that would be a longer discussion.
So we could make it the first week of November, you're saying?
Only if it's like Monday.
Monday.
Because this date, we have a lot of staff that are away. The attorneys are away, and you need attorneys there for case review. So the 6th and 7th, they will likely be elsewhere.
And is there a reason we couldn't have it Monday and Tuesday?
There isn't, but you guys typically do not do that. So.
I mean, the old date that was planned was the 14th or so, 13th, 14th. I think if you have to miss it, you have to miss it. My own personal feeling, and that's okay.
Also, if it is virtual, it might be easier for some people to come to at least some of it. or one day. It's not both. So there's options.
Any other comments? Didn't we have two people made a motion and a second or not? Sorry, it's 11:01.
Second.
Yeah, motion second.
All in favor, say aye or raise your hand.
Aye.
Anyone opposed? No. Okay. Thank you. It passes. We can sort out the details of what's virtual and what isn't later on.
Thank you.
All right. This is one of the reasons we want to have more frequent business meetings, because it's now 11:02.
Right.
So, and that. So we now have a few items that we have to go through. Are there any committee or work group reports other than what Dr. Curry wrote in the report? I don't see any hands up, so good, we'll move on. The next thing is rulemaking. Amelia, can you talk about this?
Yes. Okay, so we have a few things to discuss as far as rulemaking goes. The first one is a memo to initiate standard rulemaking. So as part of the rulemaking you have open right now, that many people commented on earlier in the meeting during the public comment period, we have a very narrow focus, and we've received a lot of comments about that rulemaking. And so at the last workshop for that rulemaking, the commissioners on that panel decided to put forward a request to initiate rulemaking based on those comments. And so those comments are all included in the packet. And today, what you're doing is you are voting whether to initiate rulemaking based on this request or not. And then if you do initiate rulemaking, my ask from you is to determine whether you're going to be broad in the scope of the rulemaking, or if you're going to be narrowly focused only on what these comments are requesting.
Right. Is there any discussion of the first part of whether to initiate rulemaking? We did recommend that we do from our past meeting. And that, any comments about that, Claire?
So what Amelia just brought up about making it more broad, I think that
Well, I'll deal with that second. Yeah.
Okay,
yeah.
second.
If we don't want to initiate rulemaking, then we won't get to that yet. So
okay.
Any comments related to just whether to initiate or not? Okay, can I have a motion to initiate rulemaking?
So move.
A second?
Second.
Okay. All in favor, say aye or raise your hand.
Aye.
Anyone opposed? Okay, step B is that's approved. We need to discuss the scope of the rulemaking, whether it should be broad or narrow. Claire, you had a comment about this.
Yes, and I was part of the initial opioid rulemaking, and I think it is time for quite a bit of it to be all changed. There needs to be review of current literature. I think we do need to look at chronic pain patients, how that is managed. And it's all over the board. And I also wonder if we couldn't include, when we did the initial rules, we included people from the pharmacy network or committee or commission, whatever they had, because some of the problems come up with filling these prescriptions in the pharmacies. And I think there is a need to look at this forced reduction that people have, the forced tapering, and to really get a new set of information out to the physicians where we highlight some of the problems we're having. So I think it needs to be broadened. That was a short way. And, we went all over the state and we had a lot of public input in what we were doing. I think this group needs to have some public input and some literature input to really update where we are. So public input and pharmacy input would be helpful with this group, like we did the first time.
Yeah, thanks, Claire. I also feel the same way. I think we tried to make changes in the thing to say you don't need to taper patients, but it's not worded in a manner that physicians and PAs understand this. And there's been a lot of issues. And as we've heard and this morning, as well as from the written testimony, it's hurting patients.
Yeah, in the organization I've worked in, there's a number of, it's connected to a large group, and California in this large group is handling things a little differently than we are. And so when people change from another state, there needs to be a way to bring them in as legacy patients and sort things out over a longer period of time with them. Because there are people that have been in states where they are doing forced tapers, et cetera. So that's also needs to be part of what we're talking about.
Diana, I see your hand raised. Oh, sorry.
Thanks.
Yeah.
Oh, thanks.
I would also say I'd like to be on that group. I don't know exactly why I'm not involved as more in it, but just because I know the initial rules pretty well.
I had a question, which is Amelia, you asked, like, should we make it broad or narrow? And I guess I wasn't 100% certain what that meant. So I thought that the petition that came from Maria Higginbotham that we heard from today, as well as all the written comments, the 3 points that were made, the 3 specific areas that she recommended changes in the verbiage, sort of more explicit, why not to taper, when to taper, all those, the 3 points. Is that narrow or is that broad? I wasn't sure what was meant. If someone could help me out on that, because I thought that in and of itself was great.
A narrow focus would be similar to what you are looking at in the next agenda item. That rulemaking is very narrowly focused. We were only exempting sickle cell patients. We were only adding some language about tapering and things like that. And then about the biological specimen testing. That was the only thing that rulemaking was supposed to address. So we didn't open all of the prescribing sections. So you can, that's what I mean when I say narrow or broad. If you want to open all of the PA and the MD opioid prescribing sections, that would be a broad rulemaking. That way we can look at every section. Or if you want to be narrowly focused, we would only open the sections that are affected by what you choose to do rulemaking on. So if you only want to open exemptions, like you have in the rulemaking we're looking at next, you can do that. If you only want to open the section about tapering, that would be narrow focused. So that is my ask, what you would like to do.
I see. So the 3 things those points that were made in the petition were to add rare diseases along with sickle cell and to make more explicit the language about there not being an upper MED, and then also to make more explicit the verbiage about not tapering stable patients. Those already are kind of in the existing rulemaking, right? Those 3 points kind of fell already within the areas that we already were discussing, I think. Right?
And in this request, you're correct. But in this request is based on the comments we received as part of the rulemaking you already have open, not as part of that petition. So that's another decision you're going to get to make later, whether you want to, and we may be able to join those 2 together. We're going to address the petition in this initiation. You can also do that.
Right. I just thought that after reading all of the comments that came in and hearing from everyone, they kind of fall into those 3 buckets pretty nicely for the most part. So, okay. Thank you for clarifying.
Gary?
Yeah, I think one of the major asks on the part of the public that we've heard over and over is adding in the rare diseases. And these are different than sickle cell, which we know to be a fatal disease. There's some over 7,000 rare diseases. And I think, you know, a group of us and maybe some external experts are going to have to look and say, do we want to include all 7,000 and then the interpretation in between these 7,000 of, well, it's sort of like this, but it's not really. And, you know, I don't want to make a decision that then reverses some of the strong work that's been done already and open up another Pandora's box.
I'd like to echo that sentiment.
Yeah, it's certainly you can't enumerate all the diseases. And the
Right.
reason why, for anyone who doesn't remember or know, the reason why we made the change with sickle cell anemia is that was a change based on the CDC guidelines, the updated CDC guidelines. And you know, that was why that was chosen. But we could add more language relating to chronic pain patients in general, and people are on long-term opioids, right? They have long-term chronic pain and degenerative diseases or some sort of other thing. But I guess the thing that came out before is we had a very narrow focus to focus on updating to the CDC guidelines. We spent time doing it. We then spent time at the meeting doing it. And then we find there were things that were still unclear with the language that we used to put in. And then we are going through this again. And so to me, having the more narrow focus, there's good things. But if there are other issues in this document that still lead to misinterpretation and, you know, which my impression is there is a lot of misinterpretation of it from our providers in the state, you know, then having a broader focus might allow us to change that rather than bringing it back in another, 4 or 5 months and then having to go through the same thing again. So,
and that's my suggestion, is to make it a broad, you know, write the 101 really broadly and include all of the MD and PA opioid prescribing subsections in that rulemaking. That way you can address any of those that we get comments about. You can include that as part of your discussion and the rulemaking. And so that's my suggestion.
I get it.
There, your hands raised.
Yes, I got it. I wanted to say thank you, Amelia. And I also agree it should be broad. Absolutely. I do think there is a good thing about releasing some of these as individual pieces of information to physicians to highlight. We do not approve the forced tapering, or if we give a whole new document, it may still be a little blurry. So I would hope if we broaden it, we could still have individual things come in that we release to give a heads up to physicians to try to change the culture around what the commission is really doing. And I think we could do that.
As part of 1427, we did do like a roadshow where we went around the state and presented the new rules. And I think Dr. Roberts did a lot of those presentations. Jimmy's on the line. I'm not sure if she'd be willing to go through the roadshow again, but that is something we could do once the rules are finalized, is we could do a roadshow again where we allow any provider to come and they can, you know, ask questions of us and things like that. So, I mean, that is something we can totally plan.
Yeah, and I think being able to tell the medical community the problem that they're creating, highlight maybe in our messages to the physicians, things like you don't treat chronic pain is not an appropriate way to run a practice. I think they can do it, but what it's causing in this group and the need to own what physicians are doing with patients as a collective group and not say, well, I won't do it because it's too complicated or too dangerous. And I think we need a number of things to go out to the physicians. That's all.
Great. Any more discussion? Can I have a motion?
I'd make a motion for opening it up for the broad thing so that we can address all of the concerns from the public and kind of get it all in there and make the items explicit that need to be explicit. And like, you don't have to do a forced taper. You don't have to not give more than 120 MED. Some of those things I think would be important to highlight. So yeah, broad motion.
Second, Dr. Murphy.
Second.
Good. There was some kind of email, Amelia, that just came through. Can we take a vote now? Is that okay? Do I have to answer the email?
Sure.
Yeah.
No,
Okay.
go ahead.
All in favor of the motion, say aye. Raise your hand.
Aye.
Aye.
Yeah. Anyone opposed? Okay, that passes.
Thank you.
Great.
And then the next item is also about opioid prescribing, but you already have rulemaking started for this particular rule, and you had a hearing at the last commission meeting, the business meeting, and there were some concerns about a removal of some language that was already established, and so we've added that language back in. And we need to have another rules hearing, which wouldn't be until October. And that is my ask today, is that I think what we're going to do is write like a supplemental CR 102, because you already have one in place that has not expired. And we're going to change the language, and the language is in the packet that we changed. And we added back in that they should do biological specimen testing. So that is my ask here today, is that we do a supplemental 102, which is for proposed rules, and then we will hold a hearing in October for this rule. And then that will make the language that's in the packet permanent once you approve it at hearing in October.
So move.
Do I have a second? Good. We have a second. Any discussion or comments? All right, all in favor of initiating CR 102 for general provisions of opioid prescribing and tapering? Anyone opposed? Nope. All right, that passes. All right.
Thank you.
Last item.
We have the petition, which with your approval of the first item, you're covering what's in this petition. Because you are opening broadly, you are going to address this petition as part of that rulemaking. You can include this petition as part of that rulemaking. So I think you kind of already approved it, but I would like a vote for you to go ahead and approve initiating rulemaking and include it with that first rulemaking that we will be doing.
Okay.
So moved.
We have a second? Great.
Second.
All in favor? Say aye. Raise your hand.
Aye.
Aye.
Opposed? Right. Well, good.
Thank you.
We now have the policy committee report. Ms. Blake had emailed me earlier saying there was the computer issues in her hospital.
Dr. Domino, can I make a suggestion?
Yeah.
I'm sorry to interrupt.
Yeah.
I think we're probably okay deferring everything on the policy in the interest of time.
Yeah, I know.
And
it's
the
getting
time
late.
that we've already spent. Yeah. We're okay deferring everything on the policy committee agenda. Staff is anyways, with the exception of 8.5. And that's something that Micah and staff need input from you on, and then we'll move everything else to October if that works for everybody.
Great.
Heather, I don't know if we need to have a vote on deferring 8.1 through 8.4 or not. But again, in the interest of time and honoring the commitment of everybody to being here, I think we're probably at a point where that's okay.
Yeah, I agree. I think the chair can defer those or table those and then just consider the one item that you identified.
Okay, so that I agree. We will defer those due to the late hour of this meeting. And the next item, the item deals with the clinical experience assessment. We heard a lot about that. Micah, do you have anything more to say about it or anything?
Just as far as clarification goes, again, this is something that was put together by the International Medical Graduate Work Group. Specifically, the entrustment scale was put in place and sort of crafted by a Dr. Judith Powles, who was part of the Family Medicine Residency Network for many years, and so that's a lot of where it was lifted. It's meant to be collaborative with those entrustment scales. This, and I will go ahead and apologize, got dropped a little bit about a year ago, and it went to the Secretary's office for review, and then it just never came back. So this has come back with the Secretary's office recommended amendments. There were some that were okay. There were some that went against what the entrustment scale was, and so we were recommending, as you see here in front of you, this CAE, or this tool, is meant to be used with the supervised practice of clinical experience license holders. The recommendation is that the supervisor does it on a quarterly basis to track improvement on skill set. And it also can serve as documentation to program directors for what that clinical experience licensee has been doing. So with that, open it for discussion and ask for a vote. As a reminder, it's policy committee, so it does not require a second.
Yeah, so that's what in the policy committee approved it already. Okay, any discussion, comments? How about a motion to approve it? Or a second, whatever.
Motion to approve.
Great. Policy did the main approval. Okay, well, all in favor, say aye. Raise your hand.
Aye.
Aye.
Aye. Anyone opposed? Okay, that's good.
Thank you.
Well, we have member reports. Can I defer member reports today since it's getting late? Is that okay? Can provide a report next time. Staff reports, there are a lot of great written reports. Thanks, staff, for writing them. I don't know if there's anything else that's important that could be said very briefly by staff at the meeting.
I have one thing, Dr. Domina, I'd just like to highlight for everybody. I know there's a lot of material there, but please do note that Christine Blake and Ed Lopez are working with FSMB for the annual meeting and on their education committee. That's a really nice bit of notoriety for the commission, and also thank them for their service. Don't forget the annual meeting for next year is in Seattle. So as the host state, it's nice to have some profile on behalf of the commission. Thank you, Ed. Thank you, Christine.
Do we get free attendance, or does the commission pay for all commissioners to attend? No.
Yeah, we'll pay for it. I will already commit to that, Dr. Domina. Anybody on the commission who wants to go, we will certainly foot the bill. That's not a problem. Consider it done.
And beyond those two appointees to the SMB educational meetings, does our state have any input into any of the program?
We do, and that's in the form of Ed and Christine. So if you have ideas about speakers, that's certainly something that you could funnel to them. They have reached out to us, FSMB has, to facilitate kind of the opening welcome. That's traditionally a bit of a short address at the beginning, kickoff. And so we are working to help them get somebody online. Once that's all confirmed, I believe they're meeting here in Seattle. I don't know if Ed or Christine can verify this. I think they're meeting here in Seattle in person, the whole education committee, in August. And so hopefully that will be firmed up. But normally it's somebody in the home state who has some level of notoriety. And I am sure there will be a call for commission members to volunteer or potentially work on some of the panel discussions. But again, Ed and Christine, thank you for doing this. It's wonderful. And again, if you have interest in input or hearing what's going on, I'd refer you to them directly. Sorry, I didn't want to drag this out, Dr. Domino, but again, it's a nice piece of recognition for the commission.
That's great. Micah, your hand was up and you put it down. Do you have anything you want to say?
I'll defer to Dr. Trescott.
Okay, Dr. Trescott.
I'm just, now I'm starting to worry about October. we either need additional meetings or longer meetings to do all this work, because I think it is important, and it's important that we engage in these discussions. I don't want to overwhelm us in October, and where we can only go through half of our agenda. So I don't know if that's something that needs to be changed. And I don't know if we can.
With the meeting dates that you approved for next year, Dr. Truscott, that's something we're doing. We're going to be doing more business meetings, so we don't have this jam-packed agenda that's a slog to get through. That was a request from both Dr. Domino and Dr. Murphy. So I don't know if help is necessarily on the way exactly soon enough for you folks, but if we do get to a point where we need to have a special meeting to kind of get through some of this sort of stuff, we can do that. We can work it out down the road. But for 2025, we hear you loud and clear.
Yeah, because we went to quarterly meetings and there's too much to deal with in a quarterly meeting, especially when it's virtual. It's very challenging.
Yes. Thank you.
Great. Well, I think looking at the last page, we already dealt with the elections. So if since it's 11:27, I think I'd like to adjourn the meeting. Nice seeing everybody. Or do we have to yeah.
Sorry, just real quick, just to check in with Heather. She is on the agenda.
Oh, you were there. Sorry, Heather.
Nope, it's okay. Nothing to report. I'm good. Thank you.
I missed you. Yeah, it was like at the end of the page. That was it. Well, good. 11:28. The meeting's adjourned. Nice seeing everybody virtually.